Welcome to our explainer. Today, we're not just discussing a case, we're stepping right into a high-stakes surgical viva exam. The scenario is a tough one, a pregnant patient with a neck mass. We've got 2 lives on the line, and every single decision counts. Okay, let's dive in.
All right, you're the candidate. The examiners are staring at you, the pressure's on. They've just laid out the scenario. How you start your answer is absolutely critical. It shows them your structure, your thinking process. So what's your first move?
You start with the fundamentals, right? The first step in any clinical situation is always a thorough, focused history. This is where you start picking up the clues, piece by piece.
Okay, the examiner leans in. They want to see if you can cut through the noise and get to what really matters. What specific questions are you going to ask to start building your case?
So, as the candidate, you'd lay out these findings. The fact that she's 17 weeks pregnant, that's a massive factor that's going to influence every single decision we make. And look at this, the mass is growing but painless. That's a classic red flag for malignancy. On the bright side, no pressure symptoms like hoarseness and no big risk factors like family history or radiation exposure.
Excellent. History's in the bag. Now, let's build on that with some physical clues. The examiner wants to see your hands-on approach next.
They're testing your systematic approach here. A common trap is to just zoom in on the neck. But a good candidate knows you do a complete head-to-toe exam first, then you zero in on the mass itself.
And this is what you find, a 2 by 2 centimeter hard mass on the left thyroid lobe. Now, the crucial finding here, the thing you absolutely have to mention, is that it moves with swallowing. That clinical sign is basically screaming that this thing is coming from the thyroid gland. The hard consistency, that's another really concerning feature.
So, with a clear history and physical exam, you've got a really strong suspicion about what's going on. But in surgery, suspicion is never enough. The next logical step is to bring in the big guns, the investigations, to confirm what you're thinking.
The examiner is now asking for your diagnostic roadmap. What blood tests, what imaging are you going to order that will give you the most information while being completely safe for both mom and baby?
Okay, so you order the labs and imaging. The blood work is pretty straightforward. It confirms her thyroid function is normal. But the real star of the show here is the neck ultrasound. Why? Because it avoids radiation, making it perfectly safe in pregnancy, and it gives us an incredibly detailed look at that mass.
And then the ultrasound report comes back. And this is where your heart sinks a little. It's describing features that are highly suspicious for cancer, a big solid component, and a lot of internal blood flow. The alarm bells are ringing, and they're ringing loudly.
So we've officially moved from a simple neck lump to a radiologically suspicious mass. This is a huge turning point in the case, and it means we absolutely, positively need a tissue sample to know what we're dealing with. The examiner poses the key question. You've got the clinical picture, you've got the imaging. How do you get that definitive answer? The answer is a fine needle aspiration, or FNA. It's safe, it's effective, even during pregnancy, and it lets a pathologist look at the actual cells from the nodule under a microscope. This is the gold standard for diagnosis, hands down.
The FNA results come back, and there it is. The diagnosis is papillary thyroid cancer, or PTC. Now, any cancer diagnosis is terrifying, of course, but it's really important to know that PTC is the most common type, and especially in younger patients, it generally has an excellent prognosis.
This is it. This is the heart of the case. The diagnosis is confirmed, and now you're facing the ultimate clinical challenge. Pregnancy changes everything. Hormones can potentially speed up tumor growth, and any treatment carries risks for the baby. This is where careful multidisciplinary planning is everything.
So your initial plan isn't to rush to the operating room. First, you have to sit down with the patient. Then you discuss the case with a whole team of experts. And the consensus is to watch this thing like a hawk with frequent ultrasounds and to start thyroid hormone therapy. The whole goal there is to suppress a hormone called TSH, which can sometimes act like fuel for these cancer cells.
But in medicine, plans change. Just when you think you have a solid strategy, a new piece of information comes to light that forces you to throw that plan out the window. And this is a critical turning point.
And here it is. This is the red flag. At the follow-up ultrasound just 6 weeks later, the tumor has nearly doubled in size. It's gone from 2.1 to 4.1 centimeters. This isn't slow and steady. This is rapid, significant growth, and it changes everything. The examiner lays this new, alarming data in front of you. That watchful waiting approach, it's no longer a safe option.
The game has changed. So what is your new plan of action?
The decision is clear. The patient needs surgery, and she needs it during her pregnancy.
The safest time to do that is the second trimester. Your preoperative plan has to be absolutely meticulous. We're talking vocal cord checks and, most importantly, getting anesthesia and obstetricians in the room to coordinate a plan that ensures the safety of both mother and baby during a total thyroidectomy.
The surgery goes off without a hitch. The immediate threat has been handled, but this case is far from over. Now we move into the final phase. What did the pathology show? And what's the long-term plan for this patient? And the news is fantastic. The final pathology report confirms the cancer was completely contained. There was no sign of it breaking out of the thyroid gland or getting into any blood vessels or lymphatics. For her prognosis, this is just about the best news you could hope for.
This slide really breaks down the follow-up plan. Short term, it's all about managing her recovery. But long term, this is a lifelong commitment. She's going to need surveillance forever, which means monitoring a tumor marker called thyroglobulin, getting regular neck ultrasounds, and making sure her TSH stays in that sweet spot.
And so we'll end with a final question for you to chew on. The timing of when she presented was absolutely key. But what if she had walked in at 8 weeks pregnant, or at 34 weeks, almost at the finish line? Would you still have operated then? How does that risk-benefit analysis change? It's a crucial reminder that in these complex cases, timing is everything.